Thank you so much for joining us for our second lecture in our vascular class for sonographers. This week we're going to go over a little bit of physiology of both the arterial and the venous systems. Again, for some of you this might be a review, others it might be some new material, but we want to make sure that you have everything that you need to go forward feeling confident in your scanning. So let's go ahead and get started here. Our objectives for today are to list the various hemodynamic forces acting upon the arterial system, describe the relationships between pressure, flow, and resistance, identify the factors that control peripheral blood flow, and find physiologic changes associated with arterial disease while listing the hemodynamic factors that affect venous flow and describing the components of hydrostatic pressure, as well as identifying the forces that lead to edema formation and defining the changes that occur at rest and with exercise in the venous system. So one of the main components we have to sort of focus on to start with when we're talking about the vascular system is some components of fluid, because our blood is fluid and how it acts is going to be controlled by how fluids are typically acting in their surroundings. So fluid is anything that is going to take the shape of the container that contains it. So air's a fluid, blood's a fluid, honey's a fluid, water's a fluid. All those things are types of fluids, but we know that just from that example, fluids can act very differently. So the total energy that a fluid had is going to be made up of potential and kinetic energy. And one of the ways you can think about this is if you fill a container full of water and add a little spout, if you have a lot of water in here, that's a lot of potential energy because the fluid has a gravitational pressure on it, and yet it's not necessarily all moving out the spout at one time. So it has potential energy, and then it also has kinetic energy as it does flow out the spout. So fluids can flow from one area to another, take the shape of their container, and therefore they have potential and kinetic energy. That potential energy is the stored energy. So that's energy that is going to cause motion because of the pressure of gravity in this example. Now, in our body, potential energy plays a huge role in how our blood flow moves forward in our arterial system during diastole. So if we have a heart, which we all do, and our heart beats, we know that when it compresses in the ventricular region, we call that systole. And that is kinetic pressure that's going to push blood flow forward. Well, during diastole, those heart muscles of the ventricles are going to relax. And in that case, you might expect that blood might flow backwards consistently. But what we find is there's an effect that we're going to talk about later, that movement of the blood flow into the aorta can cause the aorta to stretch. And that stretching motion of the aorta actually creates a potential energy in the vasculature here of the aorta, so that when the big pressure from systole is gone, it contracts and it continues pushing blood flow forward, converting that potential energy into kinetic energy. So we have a lot of different considerations of how potential and kinetic energy affect blood flow, and it's important to understand these when we start looking at vascular changes or vascular waveforms in the body. Like I mentioned, gravitation actually works as a potential energy, and obviously just from personal experience, you know, if you have a tube of water that's long and a tube of water that's short, because more gravity is acting on that tube, that long tube of water, that's going to create more pressure. Whereas less gravity is on the shorter tube of water, that will be less pressure. And so the gravitational potential energy is that pressure, the tendency in our universe to want to push, or I should say pull, something towards the earth. All right, kinetic energy, as we kind of discussed, is the energy of motion. So when blood is flowing, when the water in this instance, in this example, is flowing, that's all going to be kinetic energy. Blood always moves from an area of high energy or pressure to an area of lower energy or pressure. And this is a very simple relationship that you've all experienced. So if you have, say, a PVC pipe, a hose, a tube, and you're going to increase gravitational pressure by pulling that tube, the one end of the tube, away from the ground, you're going to have an increase in pressure at that end of the tube. Therefore, you're going to get flow to the lower pressure end of the tube. If you had the same tube lying flat, the water would simply settle in the bottom of the tube. So we have to have that change in pressure in order to get flow one direction or the other. Now, hydrostatic pressure goes back to the idea that I mentioned with our two tubes here. Hydrostatic pressure, it basically refers to the pressure within the blood vessel at a reference point, which is determined by the gravity or the weight of the blood at that area. So if I had a 0 point, and in the human body, we'll talk about the 0 point is your heart. All of our blood, its ultimate goal is to get back to the heart. If I have, say, our superior vena cava, and I have gravity pushing, if my patient's erect, and I have gravity pushing blood down in my superior vena cava, but I have an opening in my heart willing to take that blood, then that would be my 0 pressure point. Okay. But if I look at my patient's feet, sorry, my artistic ability is not good. My patient is standing, they have veins in those legs, and then gravitational force is pushing down on that whole column of blood. That would be hydrostatic pressure, and the blood would have to go against gravity to get up to the heart. So this would be an area of high hydrostatic pressure because it has to overcome this great gravitational force to get up to the heart, whereas my subclavian or my SVC here, that's going to be an area of low hydrostatic pressure because it's going to encounter very little resistance in getting back to the heart. Okay, that brings us to the Bernoulli principle. So when I think about the Bernoulli principle, it's actually quite simple. It says that when we have a narrowing of a diameter of a tube, which in our case is going to be a vessel, that our blood flow is going to increase in speed, and when that happens, it will have a decrease in pressure. So as velocity increases in our vascular system, we have a decrease in pressure, and that's Bernoulli's principle. So you might say that, oh, at a stenosis, I'm going to have a lot of pressure in that stenosis. That's incorrect. You're going to have pressure before that stenosis. You're going to have higher pressure after that stenosis. But at the stenosis, where the blood is moving at the highest velocity, you're going to have a drop in pressure according to Bernoulli's principle. Now, we're not the only ones that use this. They use this in aeronautics and engines and lots of different places, but it's very useful when we're scanning vascular. That brings us to a little bit more discussion about fluids. So fluids we know have various viscosities. I mentioned that air, water, honey, blood, they were all different types of fluids. And we know that those different types of fluids, say air compared to honey, are going to act very different. So honey, on one hand, is going to have a very high viscosity because of the friction that occurs between the layers of the fluid. When we have that kind of friction between layers of fluid, we end up losing or converting kinetic energy to heat. So our higher viscosity materials are going to do what we say we inaccurately referred to as lose energy, meaning they're going to lose the speed in which they're moving. But we know energy can't be created or destroyed, so rather than really losing that energy, high viscosity materials or fluids are going to convert their kinetic energy of motion to heat because of the friction. And I don't know if any of you guys have heard this, but I remember a show a long time ago what they said, you know, you rub your hands together as fast as you can and you make that friction because friction is God's little toaster. And so anytime I think about friction, I'm thinking about rubbing my hands together and how it warms them up because that friction is our little toaster. Now, viscosity you might think of in blood if somebody were to have a very high hematocrit, meaning that they have a lot of a high ratio of red blood cells to plasma, that would thicken the blood or make it more viscous. If they were very, very overhydrated, they might have a low hematocrit, meaning very few red blood cells in the red blood cell to plasma ratio. Technically that should make a difference, but in reality we don't see it affect our viscosities or our velocities of fluid very much, but theoretically it's there. Now, inertia is the tendency of an object in motion to stay in motion or an object at rest to stay at rest. Now, we all know that this isn't necessarily how we experience the world. If I'm driving my car down 70 miles an hour and I let off the gas, I'm not going to continue going 70 miles an hour. Now, if energy is not created or destroyed, why wouldn't I continue going 70 miles an hour? Inertia says I should. However, because of the friction of my tires on the highway, I'm going to be converting that 70-mile-per-hour energy from kinetic energy to friction or heat, thermal energy, so it will ultimately do that conversion and slow my speed. So with blood, it's kind of the same idea. If I have blood flowing through a vessel, even though it may be very slight, that blood is going to have some friction against the vessel walls. And that friction is going to convert that kinetic motion of the blood flow into some heat at the vessel walls, and would be, as I increase my heat, I'm going to decrease my velocity. Now, flow and velocity are related. So flow is represented by a Q. That's how much of the fluid is moving through at a moment in time. So we can look at this relationship where velocity equals our flow over the area. Now, velocity is the rate of movement with respect to time, so we're going to express our velocity in things like centimeters per second. We would get to that velocity by looking at how much flow is occurring over a certain area. Now, I know that if I increase my area, let's say, for instance, let's say I have a flow of 2, and I have an area of 2. My velocity would be 1. But let's say I increase my area. So now I have a flow of 2, an area of 4. Now my velocity is 1/2. Now, the law of continuity is a really important law when it comes to what we're looking at with stenosis and atherosclerosis and things like that. So the law of continuity describes, it kind of goes in with support of Brunelli's principle. So it says that whether I have a small diameter vessel or tube and a large diameter vessel and tube, I will still have to move the same amount of flow despite having more room over which to do so. So if I have this narrow tube, I could be moving 10 milliliters per second of flow. Now, as my tube broadens, I will still have to move 10 milliliters per second of flow. But since that tube is so much broader, my flow will slow down to meet that quota. Now, as my tube or diameter narrows again, now I can push less through at a time, so I have to push it through much faster, so my velocities will increase. So the idea here is that I have to move the same amount of blood flow through despite the diameter of my vessel or my tube, and because of that, when my tube is very small, I go faster. When my tube is very large, I go much slower. That's the law of continuity. The other thing, if we remember Bernoulli's principle, is that also as my velocity increases, say where my tube becomes very small, 1 centimeter compared to the 10 centimeters it was previously, the velocity is going to increase, and according to Bernoulli, when my velocity increases, then my pressure is going to decrease. Now, when we look, this gets a little bit confusing when we look at the vascular system of the body. So if we were to look at a body, we might say, okay, the heart is basically our pump, and we have a large aorta coming out. That would be my large area of flow, kind of correlates to this area, this particular tube. And then that large aorta, it's going to bifurcate into large, medium vessels, eventually the small arteries, and then eventually to our arterioles and then our capillaries. So as you do this, you might say, oh my goodness, as we get to the capillaries, we're going to have very small vessels, which must have a lot of velocity, really high velocity in my capillaries. Well, the trick to this is that when we're calculating the area of our vessels, when I look at the aorta, there's only one aorta. When I calculate its diameter, I could simply do that by measuring the diameter of the aorta. Now, as that aorta bifurcates, say, into my iliacs, I would say, okay, now I have to consider the diameter of these smaller vessels. Well, I wouldn't consider them individually. I consider them all together. So if I wanted to compare my aorta to the area or diameter of my medium vessels, my iliacs, I would have to measure my iliacs, add them together, and compare to the size of the aorta. Now, as this goes on, it's going to go to smaller vessels, smaller arteries, arterioles, and ultimately capillaries. Now, there's millions of capillaries compared to how many aorta we have. We have one aorta, millions of capillaries. If I add the diameter of all of my capillaries together, that ultimate diameter is much, much, much larger than my aorta. Therefore, I know that ultimately that would be my area of larger diameter. Therefore, I would have a decrease in velocity at those very teeny tiny vessels simply because there's so many of them and we add them all together. Now, this is really important because we know from last week that we have our, our smaller arteries, and then we go to our arterioles, and our arterioles are like those stopcocks of the arterial system. So if it gets neurofeedback that says, hey, I want you to constrict, we have a lot of blood here, we're good, we don't need any extra, they will constrict. If we need extra blood flow, they're going to dilate, and they're going to control the pressure of the blood coming to that point. But beyond those arterioles, then we go into the capillaries, and the capillaries are little teeny tiny vessels that really only allow about one red blood cell through at a time. This is not an area we want high velocities. This capillary is where our blood oxygen exchange, or our gases and our wastes, are going to cross that permeable membrane of the capillary. So we want it to be kind of a low, slow flow so that there's time for that exchange to occur. And so therefore, it's really important to remember capillaries, if we add them all together, ultimately produce the largest diameter, even though they're made up of many, many, many tiny vessels, the ultimately largest diameter, therefore low pressure, slow flow, and really optimal opportunities for exchange. Okay, now another law that is going to describe a little bit about what occurs within the vascular system is called Pucell's law. And I like to think of Pucell's law as the pipe law. So P for Pucell, P for pipe. Now everything about Pucell's law can basically be described with your experience playing with a PVC pipe. Okay, now one of the caveats to this is our vascular flow, our vessels in our body, they are not long, straight, rigid structures like a PVC pipe. So Pucell's law is not perfectly accurate to how flow occurs in our bodies, but it makes some really good points about that our bodies do follow to a certain extent. So when it fits, you say, oh yeah, we follow Pucell's law. If it doesn't fit perfectly, say, well, we're off because they're pipes and we're not pipes. Okay. So Pucell's law assumes that fluid is flowing through a pipe-like structure, unlike our actual vascular system. And it's able to define pressure and flow relationships in a vascular system. If you look over to the left, you see that this is the equation for Pucell's law. Now, the equation for Pucell's law, Q again is flow. Pressure 1 minus pressure 2, those are our changes in pressure because we never get flow without a change in pressure. Then we have pi r to the fourth. R would be the radius of our vessel, and we're raising that to the fourth power, which means it's going to have a significant effect on how much flow occurs. And then we're multiplying it by pi because that helps us get to a diameter. And then below the line, we see that we have 8 times the viscosity times the length. Now, one of the things that is really important is that, and we can draw back to our own experiences, if I have a very small radius PVC pipe and I have a very large radius PVC pipe, if I provide enough flow to fill that PVC pipe and this PVC pipe, which one of them is going to allow more water to flow out on the exit end? Obviously, the larger radius pipe. Okay, so we know that if I increase my radius of a vessel or of a pipe, that should increase my flow. Okay, now we just read the law of continuity says no matter what my radius is, I'm going to try and maintain the same flow. That's how our body differs from a pipe in Pucel's law. Our body doesn't want our brain to get a ton of flow sometimes and a lot less flow other times. It wants to maintain constant, steady flow. And so our body really follows the law of continuity, although if we were working with pipes, we would see it follow more this Pucel's law. The second thing that's really important here is the length. So if I have 2 equally sized PVC pipes that have pressure changes that are exactly the same, but their length is different, as I add water to these, the longer pipe is going to experience more friction and therefore lose some of that kinetic energy of flow and have a decreased in flow on the exit end than my shorter pipe. Less friction, less loss, more exit flow. Longer length, more friction, more loss, less exit flow. Okay, and that really draws to the third point. It really kind of ties it all together. Changes in resistance are due to changes in vessel radius. Now, we did see that we have a couple other things. So pi really referred to our diameter, r to our radius, pressure 1 and pressure 2. Now, if I were to take one end of the pipe and raise it up higher, that would increase my flow versus a pressure change that was much more subtle. Right? I'd get a lot more flow through this pipe because I have a bigger pressure change between here and here than I would get through this pipe because it's more of a subtle pressure change. So we talked about how our radius and our diameter affect the amount of flow. We talked about how changing the pressure can affect the amount of flow. We talked about the changing of length can change the amount of friction, which will affect the amount of flow. And then lastly, viscosity. Imagine that I have 2 pipes equally positioned. Same pressures, same radius, same length, everything about them is the same. I fill one with honey, I fill the other with water. Which one is going to have more flow? The one with water, obviously, because it's less viscous. So as I increase my viscosity, I'm going to decrease my flow. Now there's a couple different types of resistance. We can talk about resistance in parallel or resistance in series. I won't spend a ton of time on this, but resistance in parallel would be if we had 3 different vessels set up side by side running parallel to one another. How would we calculate the overall resistance of the vessel coming into those 3 vessels? This might be something like a system where maybe you've had some kind of stenosis and your body's built up some collaterals, and we wanted to calculate the overall resistance of all those collaterals together. The equation for this would be 1 over resistance equals 1 over resistance 1 plus 1 over resistance 2 plus 1 over resistance 3, and that would give us our 1 over resistance in parallel series, or excuse me, in parallel formation. Now, if we have resistance in series that we want to look at, this could be something like a vessel that has a big stenosis and then it has a nice return or to actually an enlargement post-stenosis. So this one, you would simply, our total resistance would be resistance 1 plus resistance 2 plus resistance 3. So basically it means when you're looking at resistance in series, you're just adding the resistances together. If you're looking at them in parallel, you're adding the reciprocal of the resistances together. Now, we are going to be incredibly dependent on evaluating resistance in vascular beds. Now, the idea of our vascular beds is to provide as much blood flow to a particular tissue that it needs, no extra, no less. Now, how resistant a blood flow is in a particular bed is going to depend on the metabolic needs of that particular tissue. So just for instance, if we were to look at a brain, again, I know I'm a terrible drawer, so I apologize. If we look into the brain is always processing. Even when we're asleep, our brain is functioning at a high level. That brain is going to need blood all the time. It's going to have a very high metabolic rate. Now, if something needs a lot of blood, should it resist it or should it accept it easily? I would say if you need a lot of blood, you accept it easily, and so it would put low resistance against the blood flow coming in. So these arterioles would maintain relatively dilated. We'd provide plenty of blood, oxygenation to the area, nutrients to the area to help our brain function well. When we look at what a waveform in a low resistance vessel should look like, we will see that we have a strong systolic upstroke, meaning that when my heart's ventricle squeezes, it immediately pushes blood forward. You can see it going very quickly from a low velocity here to a very fast velocity maximum. Now, as the heart goes into diastole, it's going to start to relax, and our blood flow is going to continue forward motion. We see that because here's my baseline. Anything below my baseline would mean it's going in the opposite direction. So if I'm still above my baseline, that's telling me that, yeah, it's going to continue forward motion. But if I were to look at the speed of that forward motion on my scale over here, I would see that the speed of forward motion is going to drop off at the end of systole. So systole occurs, red blood cells move forward very, very quickly. Diastole sets in, the forward flow is going to slow down, and in a very low resistance bed, remember how I mentioned that potential difference that accumulates, or that potential energy that accumulates in the vessel wall when it expands, when it gets filled with all that systolic blood? During diastole, if there's very little resistance ahead and that potential energy is released by the vessel compressing one more time, it will continue to cause forward motion of that blood flow because there's such little resistance ahead. And at that point, systole would occur again, and you'd see the same pattern. Okay, so that is how resistance works with our low resistant patterns. So we see this nice low resistance area. Anytime you're wondering what a vessel should look like or what the blood flow should look like, think about what the metabolism of that particular tissue bed is going to be. So things like our brain, our liver needs a lot of blood flow. Our coronary arteries would need a lot of blood flow. Our spleen, all of those things, our ovaries, our testicles, things like that, they're going to require a very low resistance bed because they have a high metabolic rate and need lots of blood flow all the time. So we see something like this. Now, on the other end of the spectrum, we have high resistance flow. Now, our high resistance flow, I usually think about this as it correlates to muscles. If I'm at rest for a long time, I've been sitting here for quite a while today. So if I'm at rest for a long time, my muscles of my legs are not working very hard. They're not going to have a high metabolic requirement right now. And so what happens here is, if again we have our heart, systole occurs. Now, if the vessel is nice and open, systole occurs, it's able to push that blood flow forward quickly. And then as diastole sets in, that ventricular area begins to relax, there's quite a bit of pressure up ahead towards my leg muscle. Let's say this is my leg muscle. Okay, there's quite a bit of pressure up ahead because those arterioles in my leg muscles are sensing that they don't need a lot of blood flow right now. So those arterioles are going to constrict, providing resistance in my vessel. So I get that good systolic upstroke, and then when that systolic contraction discontinues and I go into diastole, the pressure from up ahead in this constricted arteriole is actually going to first slow that blood flow to a stop, because you see it go all the way to the baseline. That means it's stopped. And then you even see it go below the baseline. And that means that that resistance is so significant that not only it stopped that forward flow, it pushed it backwards. Now, so we would call this early diastole. Now, end diastole is a moment later. We know that this vessel had collected a bunch of potential energy when that vessel expanded. And now that there's no pressure from systole, that vessel can contract to its normal size. So with the Windkessel effect, or that release of potential energy, it's going to give one more squeeze to push that blood forward and end diastole just a little bit. So we have systolic upstroke, early diastole, early diastolic reversal, and diastolic forward motion. And then we start the whole process again. So that would be something that we might see, this high resistance blood flow in things like our muscles. It occurs because neuroreceptors in those muscles determine that the metabolic needs are getting met, and it doesn't need a lot of blood flow, so the arterioles contract. And when those arterioles contract, they provide resistance to the incoming blood. Now, just because a vessel is high resistance at some points, just like we're seeing here, doesn't mean they're always going to be high resistance. Let's say this is my leg muscle. Let's say it is my popliteal artery here, and I've been at rest. Hike, I'm exhausted, I put my feet up and you did this exam again. Because my metabolic need would be much higher, it would trigger my neurons to cause my arterioles to dilate, and you'd see a much lower resistance vessel. Same thing with our mesenteric arteries. Our superior mesenteric artery that comes off of the aorta is generally pretty high resistance if we haven't had a recent meal. But if you re-examine somebody postprandially, you'll see that that meal causes an increased metabolism in that area, and you'll see a much lower resistance waveform. So always be aware of the state of the patient, whether they've been at rest, whether they've ate, depending on what vessel you're looking at. Those things are going to be very important. And that's just kind of what I was mentioning on this slide. One of the things is, if you're doing a lower extremity arterial, that's why it's going to be so important to have your patient rest a little bit before you start the exam. Some of those patients are going to be, low activity generally, so just getting into the hospital, up and down the stairs, so on and so forth, can cause a big change in the metabolism of their muscles. Now, flow patterns, different. Well, all of our fluids are going to have what we call a flow pattern, and we can describe these flow patterns in a number of different ways. One of the most important concepts to think about with flow patterns is laminar versus turbulent flow. When we have laminar flow, it means basically, if we were to say this is a blood cell, so on and so forth, that these blood cells are moving parallel to each other. They're not whooshing in front of each other, behind each other, they're moving in parallel. So whenever we have blood flow moving with our cells moving in parallel lines, we call that a laminar flow. Now, most of our blood flow is going to be laminar. Now, there's a few different types of laminar flow. You see here that if at the origin of a vessel, as our blood enters that vessel, all of the blood cells are moving at relatively the same speed, but they are running parallel to each other. So this is kind of like a very close horse race. They're all running at the same speed. This would be laminar plug flow, because it looks like the plug of a syringe. Okay. Now, as that blood continues to go down the vessel, the walls are going to act on those outer layers of blood cells more than on the inner layers of blood cells because of friction. So we're losing some of our kinetic energy to thermal energy due to friction here on the periphery. So our center cells kind of take the lead, and our peripheral cells run a little bit slower. This we would call laminar, again, because all of our cells are moving parallel. And then we call it parabolic because there's a slight curvature in how they're moving. The center is moving faster than the lateral regions. Now, this becomes very important when you're taking velocities in a vessel. When you're taking velocities in a vessel, you want to make sure your gate is right there to detect the highest velocities. Now, theoretically, they say that parabolic flow doesn't occur very much in the human body because our vessels are never long and straight enough for it to get to this point. However, you're going to see certain exams where you swear it's occurring, and so that's, that's up to you. All right, now, if I don't have laminar flow, if they're not running parallel to each other, we call it turbulent flow. Now, turbulent flow means that if this is my vessel and I have cells from different lines of motion crashing into each other, maybe swirling backwards and frontwards, anything like that would be turbulent flow. Okay. So that's irregular motions of fluid elements mixing between layers occur. There's greater pressure is required to move fluid under turbulent conditions to get it moving again. And this you could correlate to a small waterfall. Everything is coming, and you can imagine those little water cells. They're moving nice and parallel as they come down the waterfall, so smooth and beautiful. Now when they hit the base of the waterfall, you see all this rumbling, bumbling, and all this churning up. That's the turbulence. And it's going to take more pressure against this turbulent water to finally get it stretched out, moving back in laminar flow again. The same thing occurs in our blood vessels. So one of the most common places you're going to find this is if you have a nice blood vessel here, and then you come across a stenosis. Okay, we have nice laminar flow coming in here. We get into a stenosis. We know that's going to give us an increase in velocity with a decrease in pressure. As it exits the stenosis, all of a sudden, this little bit of blood that came through is going to have a lot of room to move in. So what's it going to do? It's going to start churning or become turbulent. Okay. Now, eventually, it should be able to get back on its way in a more normal laminar pattern, but often the pressures here can never be depending on how significant that stenosis is, you can never repeat the pre-stenosis pressure post-stenosis. Now, one thing that is going to help describe when turbulence will occur is called the Reynolds number. The Reynolds number takes a number of things into consideration, such as the velocity of blood, the density of blood, the radius of the vessel, and it is going to increase. As any of those things increase, then the Reynolds number increases, and once you surpass the Reynolds number, then it predicts that turbulence will occur. Whenever the Reynolds number gets above 2,000, that's the predicting point. Now, you guys don't necessarily need to be able to calculate the Reynolds number, but what I would understand about Reynolds number is that anything over 2,000 indicates turbulence will occur. All right, now I've talked quite a bit about our Windkessel effect just as it related to other topics as we were going through them, but we'll want to go over it just a little bit more here. Now, one of the things about the Windkessel effect is, unfortunately, it has multiple different names depending on the source that you're looking at. So I believe, in lots of physics books, they call it the Windkessel effect. In, some of your more vascular-based literature, you're going to see it called the hydrostatic pump or the hydraulic filter. And it's just as I described before, where it converts intermittent or pulsatile output, such as when the heart goes into systole, and it is going to retain some of that filling as potential energy in the walls, so that when the end of systole comes and we enter diastole, it can compress and continue forward motion. And this is a true help to the capillaries in maintaining just a nice, consistent, low flow right at that capillary level to maintain consistent nourishment of the tissues. Now, one of the things the Windkessel effect can be very reliant on is the health of the vessel. So if a vessel has a high degree of atherosclerosis, it will lose what we call compliance. So compliance is the ability of the vessel to expand and contract. They also can call that capacitance. It can take on more or less capacity. So compliance or capacitance is essential in your Windkessel effect. Now, if you were to have a lot of ather or arteriosclerosis, and it would harden the walls of that vessel. It's going to have much less ability to store that volume, or pardon me, store that potential energy, and so it will not have as an effective Windkessel effect. We already talked a lot about systole and diastole, so when just a quick review, when when our ventricles contract, it's going to force our arterial blood out into the aorta. So during that contraction, we call it systole. Blood is going to have a significant motion forward that is going to almost overfill the artery. Because the artery is going to be stretched, then that's going to retain that potential energy in the wall. Diastole sets in, the muscles are going to contract, and that forward pressure of blood flow is going to be reduced so that this blood flow will then slow significantly. Now, if I have a nice compliant or high capacitance vessel here, we're going to have the Windkessel kick in again and push the blood flow forward again. And that would look something like good systolic upstroke, maintaining early diastole motion because of minimal resistance ahead, and then Windkessel keeping it moving forward. All right, we talked about a little bit about this with the controllers of our peripheral resistance. So peripheral resistance or circulation is controlled by our central nervous system ultimately, that controls how our arterioles react in order to provide vascularization to our tissue bed. So our central nervous system has little monitors out in, and this is very simplified obviously, little monitors out in our tissue beds that are going to basically be taking readings of, you know, oxygen levels, carbon dioxide levels, things like that. And it is going to trigger the arterioles to constrict or expand to work with the needs of the tissue bed. So if our carbon dioxide is getting too high, it's going to cause arterial dilatation so that we provide more blood flow to the area. It can get those wastes out and deliver more oxygen. If, let's say, the oxygen level is really high, then it might constrict that area to slow down the blood flow to the region, which would allow it to become more homeostatic or maintain those normal homeostasis conditions. The arterioles that allow blood to go from basically the rest of the arterial system into the capillaries. It's really those arterioles that are going to control this. And again, those are the stopcocks of the vascular system. And they're going to be working off of oxygen and carbon dioxide levels, hydrogen and potassium ions, and blood pressure. All right, now we know that everything we've really talked about really assumed that most arterial systems were working properly. We know that that's not always going to be the case, and that there can be some. Now, some of those plaques are going to include a fatty or lipid streak. This is going to be more common for people that have high cholesterol, things like that. We can also have fibrofatty plaques. Fibro really is going to refer to kind of fibrous material or scar tissue kind of material mixed with fatty plaques. So these might come from some vessel wall disruption or injury and high cholesterol. Then we can go with, then there can be fibrous plaques. Those are probably going to be more associated with injury to the wall. Now that injury doesn't necessarily have to be trauma or iatrogenic where it was damaged during a procedure, something like that. It could actually just be injury from, you know, having high blood pressure, having diabetes, having high nicotine levels from being a smoker. All of those things disrupt that vessel wall and then would cause this sort of fibrous scarring type reaction. And then there can be complicated plaques, which could be, you know, fibrous material, fatty material, ulcerative material, all mixed in. So where we find most of these atherosclerotic changes initially is going to become at the bifurcations. And this is really because if I have a vessel coming in, it bifurcates, and I have nice laminar flow, I'm still going to kind of have some of those blood cells crashing in to that bifurcation. And when we have those cells along with whatever the blood is carrying, such as nicotine or extra sugars or things like that, it's more likely to do damage at that area initially. And that once that damage is done, that's when things start catching on it and building up, like our fatty lipids or different things. So most of the time, our first place we're going to see is plaques are going to be at our bifurcation. Now, once disease becomes more and more prominent, you'll see it spread throughout the system, so it could be anywhere. Stenosis account for most of the abnormal energy losses in our system. So we know that friction creates heat. Heat is a conversion from kinetic energy of blood flow into thermal energy, which would mean that we have a decrease in kinetic energy of our blood flow. So most of that friction is going to occur on these really irregular plaques or stenotic areas. There's going to be a high significance of, first of all, because of the law of continuity, we're going to increase our velocity. Because of Bernoulli's principle, we're going to decrease our pressure. And then because of friction, we're going to increase friction, which would cause an increase in heat, which ultimately after the plaque would then decrease the kinetic energy or the overall velocity because that kinetic energy was lost to thermal energy as heat. Radius changes have a greater impact on flow than anything else. This really goes back to if we looked at Pucell's law, you notice that the upper half of the equation was pi times pressure 1 minus pressure 2 times radius raised to the fourth. And because that radius is raised to the fourth, the radius is going to have the more significant impact on flow than anything else. Therefore, we know when we have a stenosis, we have a significant change in radius from here to here, and it's going to have a major impact of how much flow is exiting. Now, once that flow does exit the stenosis, we can expect turbulence and a high Reynolds number. Now, arterial disease becomes most concerning when it has hemodynamic significant changes. That means that the narrowing of the artery has caused a significant stenosis enough that it will actually affect the velocities and pressures within the vascular system. Now, most of these stenotic events usually are not hemodynamically significant until the cross-sectional area or the whole area of the vessel has been occluded up by about 75%. The cross-sectional area occluded by 75% with the diameter reduction of 50%. Once that has been achieved due to the sclerotic events, that's when you start seeing those changes of our hemodynamic effects. So hemo meaning blood, dynamic meaning changing. So that would be changes in how our blood moves throughout the vessel. Now, one of the things that can occur when we have a hemodynamic significant change or a critical stenosis is that our system can build collateral vessels. Now, collateral vessels, as you know, are vessels that are not original to a circulatory system but can develop. So in our vascular system, we have pre-existing pathways that are basically fibrosed off. And unless there's a lot of pressure, so say if I had a stenosis down here causing a lot of backup of pressure of blood flow prior to the stenosis, that increased pressure could cause that pathway to cannulize and open up and become a collateral vessel. This is an excellent mechanism to compensate for stenosis. It will allow blood to get around a stenotic area and still provide vascularization to tissue beds that would otherwise be obscured. So one of the considerations, however, is if your system has been really effective in building up collaterals around a stenosis, some of the pre-stenotic indicators that we look for in blood flow will not be apparent. So if I just had a stenotic event and I didn't have any collaterals developed, because of that restriction in arterial size, I would start to see a more resistant waveform. Now, if my system was able to build collaterals, it would provide alternative pathways, which would then reduce the amount of resistance caused by that stenosis because it's being bypassed. In that case, my waveforms prior to the stenosis might appear relatively low resistance still. That doesn't mean there's not a stenosis there, it just means it's already been compensated for with the collaterals. Claudication. So claudication occurs when you have a critically significant stenosis and you exercise. So a lot of our critically significant stenosis is still, while it still has a significant stenosis, it changes the hemodynamic effects. You're getting that increase in velocity. You're getting a little bit of turbulence post-stenosis. That's significant events. Now, if a person is not very active and say their muscles don't have a lot of metabolic requirements, even though there's a significant event here, they may still be able to function normally, have no pain or anything else. However, if they exert themselves walking to the mailbox or doing something else active, they might then start to experience pain. The pain upon exertion when you have a critically relevant stenosis is called claudication. So for example, if I had a patient whose legs felt fine all the time, every day, except for when they walked to their mailbox and back, and at the same point as they walk to their mailbox, a half mile from their house, at that same point on the road, they start to get pain in their leg every single time they do it. Well, as they're walking, they're gradually increasing the metabolic need that their leg muscles have. And as that metabolic need exceeds the vascular supply that artery can provide due to the stenosis, that at that point they'll start having pain every single time. So that is the effect that claudication has on the patient's body. Muscular pain at the same level of exertion every single time due to a critical stenosis. Now we're going to look a little bit at the venous physiology, which is a little more simplified than our arterial physiology, but you have to approach with a slightly different frame of mind. So for our venous system, one of the most important things to remember is that our heart system, the blood flow through our arteries, is controlled by a pump, which is the heart. And that, as long as that heart keeps pumping, we keep having pressure changes that's going to force blood up into that arterial system. We know that blood goes from our large arteries to our medium arteries, down to smaller arteries, small arteries, arterioles, and eventually capillaries. Now, as those capillaries allow permeability of nutrients and waste, on the other side, it's going to connect with a venule, and that venule will absorb waste. It will lead to larger or small veins, which lead to medium veins, which lead to larger veins, to ultimately it becomes the superior vena cava and the inferior vena cava. Now, at the capillary bed, we talked about how this should be very continuous flow through the capillaries. There shouldn't be a lot of pulsatility. We want continuous flowing going here so that we can get really good exchanges across that permeable membrane. Well, because at this point we really lose pulsatility in our vascularity, on the venous end, we actually don't have any pump moving blood up through the venous system. So venous capacity is going to be really dependent upon pressures. So the veins are have a high compliance or high capacity, meaning they can go from almost collapsed or completely collapsed when they have low pressures inside to all the way dilated to a nice round large vessel when they have large pressures of blood inside. So distended veins can actually become up to 3 to 4 times the size of the correlating artery. So your jugular vein would be up to 3 to 4 times the size of your carotid. when it is at its maximum capacity. The other thing about the veins, though, is that if they have no thrombus in them, they should be fully collapsible, which is different than our arteries, which have that thick muscular layer or tunica media, which won't allow them to be collapsed. Now, usually in our venous system, we have 2 veins for every artery, and the venous system is going to collect the venous blood. And whereas we think about on the arterial system, all of our arteries are bifurcating, starting as one right there at the aortic root, and it's always bifurcating, producing new branches. When we're thinking about the venous system, the origin is really at the most distal, tiniest part of the body in those venules, and they're going to anastomose or come together into larger and larger veins until they ultimately reach the right atria of the heart. So now the vein shape plays a large role in providing venous resistance. So the veins do act a little bit resistant to filling with blood, and that's because of the ability of them to kind of collapse and expand. So you see that when there's a very low transmural pressure, now trans means across, mural would be muscle, so across the muscle pressure. So if I have a high transmural pressure, that would mean that I have a very distended vein pushing out the muscle. If I have a low transmural pressure, then I have the muscle pushing in on the vein. So high transmural is pushing out, low transmural is pushing in, and it would be collapsed. Okay. That's the ability so that our body maintains some blood flow in all of our veins rather than just completely collapsing at certain times. It's kind of that shape of the collapsed vein and that transmural pressure which can prevent that. So if we don't have a heart to pump if our heart's not responsible for pumping our venous blood back to our heart, we know it has to get there somehow. And as humans, hopefully we're spending a lot of time on our feet. And we know that gravity should be pulling our venous blood toward the surface of the earth or the ground, which is the opposite direction of where we need it to go because of our heart. Now, if we look at the pressures or the hydrostatics of blood, we can see that there's going to be different pressures or hydrostatic pressures. Remember, those were referring to the weight of a column of blood that's under gravitational pull. If we look at those hydrostatic pressures and how they alter throughout the body, we see that if I had an arm like this gentleman does here, raised above the head, and it's emptying ultimately into the heart, it's going to have a negative venous hydrostatic pressure because it has somewhere empty right into. So all that gravitational pull is just helping it reach its destination. Now, if he puts his hand down, you would see, and I don't have it listed on here, but if he puts his wrist down, now his venous column is going to be this long in length, and that pressure is going to be pushing down on his wrist. So he would have a positive hydrostatic pressure here. Here in his legs, he's going to have another positive hydrostatic pressure because he has columns of blood pushing towards his feet, and that's where you see, the high hydrostatic pressure here. The heart is our 0 point for our venous system. So our hydrostatic pressure is going to depend on the blood density, because the denser our blood, the heavier it is, the gravitational pull, and the height of the column of blood. So so obviously here in our legs, we're going to have the most hydrostatic pressure. In our arm, our column of blood is shorter, and so we're going to have less hydrostatic pressure. Now, if the patient lays down, it's a totally different situation. Our heart is our 0 point, and our veins, if they lie basically at the same level as our heart, we're all going to have very minimal differences in hydrostatic pressure between our leg, our arms, and our cranial veins. When standing, the hydrostatic pressure affects all venous pressure, either positively or negatively, and the pressure, the venous pressure at the ankle increases the most of any other body part when standing. With exercise, the venous pressure lowers somewhat, and the cause of that is that while we don't have a heart to pump our venous blood up, our leg muscles actually act as a calf pump, they call it. So as our calf muscles contract and restrict, they squeeze those veins, pushing the blood upward towards the heart level. And so when we exercise, that venous pump of the calf pump will help lower the hydrostatic pressure in the legs. But if we're standing, not mobile at all, that's when our hydrostatic pressure of the legs is going to be highest. Okay, now we do know that thrombus can have a significant effect on what we see in our veins. So if we have a vein, let's say I'm looking at the common femoral vein in the pelvis or in the proximal femur, and that vein is nice and open, and I'm going to take a reading here in my vein. Now, what's going to happen is as my patient breathes, I'm going to be seeing fluctuation in the blood flow through this area of the vein. So if a patient takes a breath in, so a big inspiration, their diaphragm will drop down. When their diaphragm drops down, that's going to increase their abdominal pressure. Now, if I have an increase in abdominal pressure, which is between my common femoral vein here and my heart up here, that increased pressure is going to stop the flow of that venous blood. So I might see some venous blood coming through the vessel, and then as I take an inspiration, it will cut off that venous blood, and you won't see any more movement until they expire. When they expire, the diaphragm moves up, I have a decreased abdominal pressure, and all of a sudden blood moves forward again. The same thing can happen when you're having a patient Valsalva. You're watching the blood move forward, the blood is coming through, your patient Valsalvas, which means they push that diaphragm down, increasing the abdominal pressure. That abdominal pressure pushes back against that vein, and you won't see any more forward motion of the vein until the patient releases Valsalva. Now, another thing that we use in our venous scanning is augmentation. So when you're augmenting a patient, let's say you're watching their blood flow in that common femoral vein again, and it's kind of cutting off during their respiration, and then they expire again, and you get forward flow. Now, if I am looking at my patient here at the common femoral vein, and I go down and I augment my patient at the ankle, that augmenting of the patient at the ankle, or squeezing their ankle, or having them flex their foot efficiently, is going to send a big whoosh of blood towards my transducer that I have placed here. And when that big whoosh of blood comes up, it is going to show this spike on your waveform. Now, when you get that spike, what that's telling us is that between the point on the leg where I squeezed and the point on the leg where I have my transducer, there's no thrombus in that region, which is allowing blood to spike, moving through very quickly when I apply that pressure. Now, if I were to have a big thrombus in the region and I were to go augment my patient, I might see normal flow in this region right here because it's reacting to changes in abdominal pressure. If everything's clear up the road ahead, it's just going to be reacting to those changes in abdominal pressure. So I'm going to see my what we call phasicity. It's changing with the phase of my patient's breathing. So then I go to augment, and I squeeze that ankle as hard as I can, and it forces blood flow through until that blood flow crashes against this thrombus, and it can no longer be forced through. If my transducer is way up here, I am not going to get an augment signal like I have here on my spectral waveform here. Now, on the other hand, if my thrombus happened to be, proximal to where I was scanning, so if I was, again, scanning in my common femoral, here's my transducer, I had a thrombus here in my IVC, when I augmented, that blood flow would whoosh through, and I would get a nice I would get a nice augment here. However, because my IVC is here, as my patient is changing abdominal pressures, increasing pressure, decreasing pressure, my IVC is not able to increase and decrease pressure because it's plugged with the thrombus. Therefore, I would get little to no phasicity, but I would get an augment if I was distal to it. I mentioned just previously about how since we don't have the heart to pump the venous system through, we do fortunately have the calf muscle pump that we refer to, or really any other other or muscles. So if I flex my arm, I might have the muscles of my forearm might squeeze my radius and ulnar veins. But the one we think about the most because it's the most probable to get backed up is going to be the veins of our legs. And so we really use that nice big calf pump to aid in the return of blood flow. So staying active, flexing your feet on plane rides, things like that is really just to help maintain that circulation because there's nothing else there to do it. The other thing that we have available are our valves. So our valves, like we talked about last week, are just a fold of that tunica intima. That prevents, once we get blood past a certain valve, it prevents the backflow of that blood. And so those two things help prevent our blood flow from settling, gaining more and more hydrostatic pressure, ultimately causing edema, possibly thrombus and other things. Now, if we have a failure of our valves, we can experience varicose veins. So varicose veins develop in a couple different ways. The primary way varicose veins develop is when they develop in the absence of a DVT. So you're healthy, you don't have a DVT, but maybe you have some valves failing, so you're getting a lot of blood flow, backflow basically. And that backflow provides more pressure to the next valve, and it provides more pressure, and then that valve gives out and it provides more pressure to the next valve down, and ultimately it's sort of a snowball reaction that vein is going to become more and more dilated as the valves are destroyed. Okay. Now, most of the time, the valves are destroyed over time, but they could be congenitally absent. And so that would be what causes your primary varicose veins. Now, your secondary varicose veins are caused by a DVT. So you might have pretty good veins. They have their good little valves here, here, and let's say here. But you get a big DVT, and even when the calf pump is being utilized, you can't get the blood flow past it. Now, the arteries are still dumping in blood here, so it's filling up with nowhere to go. That increases the pressure on these valves, causing expansion of the vessel destruction of the valves, and ultimately dilatation of the veins, causing these secondary secondary varicose veins. Varicose veins can also be common in pregnancy. This is really because of the abdominal pressure that the fetus can put on the IVC. So it almost acts as a thrombus. That IVC isn't able to drain as easily, especially if mom's on her back a lot or things like that. And so it causes a backup from the IVC down into the lower extremities. That extra pressure will cause problems with the veins and valves, ultimately the veins, and effectively cause varicose veins. Now, venous ulcers is even a more significant pathology that you might find. Now, venous ulcers occur because you have an increased venous pressure, which results in the distension of the capillaries. So we talked about how that capillary is where basically our oxygen and our nutrients are delivered, and then in the veins, those same little red blood cells that dropped everything off in the capillaries are going to be picking up the waste. And in those little venules, if there's an increase in capillary pressure and the vein is unable to have enough time to absorb the waste like it needs to, it ends up leaving fluids and other particles out within the tissue. That can lead to edema. When it leads to edema like this, hopefully the veins will ultimately be able to resorb some of that, or the lymphatic system can help, but sometimes it's unable to. When this happens, the junctions between the epithelial cells here in the venule or capillary walls are going to open, and the plasma proteins will just be released into the tissue. Now, when those proteins are released, they have a lot of protein movement, and that protein movement can start to break down the skin and other things. So it's kind of like an oozing vessel, allowing more protein in the area, and then the protein attacks the tissues. And this can cause ultimately an ulcer in the area. So that's why it's so important to rotate patients and different things. All right, so in summary, understanding vascular physiology is essential to examining the vascular system. If you don't understand what waveforms should look like, what resistance should be, what controls it, all those things, it can be very difficult to critically think through your exams. So really focusing on the basics until you feel good with them makes it a lot easier to complete your examinations and really know why you're doing things, not just doing them because somebody told you. It also helps you to critically think through things when you find difficult pathologies, and so it can make you a lot more successful and confident in your exams. We know that arteries and veins have similar structures, with the main difference being that tunica media, the muscular area of an artery, being much thicker. Arterial flow is controlled by the pump. We don't have that on the venous side, so we are reliant on muscle pumps and good valves to help maintain flow against a pressure gradient. And numerous rules and laws, such as Bernoulli's law, Pucell's law, law of continuity, all of those things are really important in understanding how and why the blood moves through the body, and explains why we see what we do when we're imaging it. So thank you so much for attending our lecture, and I hope you find something in here useful, and I hope you have a wonderful day. Thank you.